My name is Chet Donnelly. I'm a minimally invasive spine surgeon that practices in Dallas, Texas. Today I'm going to teach you about what lumbar spinal stenosis is, what causes it, and then how to treat it both non-surgically, and for those that fail non-surgical treatment, how to then treat it operatively. So first, let's go over a couple definitions. This is the entire spine model. You have the cervical spine, thoracic spine, and lumbar spine. The lumbar spine is 5 bones. Lumbar 1, 2, 3, 4, 5, and then sacral 1, S1. In terms of spinal stenosis, this can be in the cervical, thoracic, or lumbar spine. The lumbar spine is when it's in these 5 bones, any one of them. Stenosis is just a fancy medical term for squeezing or tightening. So if this is the spine, looking down the column of the spine, it's when this thecal sac, which is where all the nerve roots run through in the spine, the thecal sac, it's when there's a tightening of those. Now this could squeeze just all of these, or if it's on the side, could squeeze one of these nerve roots. The reason someone would get lumbar spinal stenosis is the following. So it could be something very severe, such as a tumor or an infection, or in a traumatic situation from a fracture. That's a small subset of patients, and those are those that develop very fast. Sometimes tumors or infections can develop slower, but those are very fast things that happen. The overwhelming majority of patients that develop lumbar spinal stenosis is from a degenerative arthritis or from a disc herniation. So what am I talking about in terms of arthritis? Well, it's pretty much any wear and tear or thickening of tissue. Just like we have a callus formation on our hand from overuse or doing something different, we can get these callus formations or thickening of tissue. Now, when you get that thickened tissue, just like you get that on your hands from, working outside or being in the gym, that's trying to protect your body. So this extra thickened tissue you get in your spine is a way your spine's trying to protect itself. So looking down the tunnel of the spine, between each bone is something called the ligamentum flavum. It runs in the top part. That can get thickened, builds up tissue over time, and that would squeeze all the nerves in the thecal sac. So a thickened ligamentum flavum is a very common way that just from age and over time and wear and tear, people get lumbar spinal stenosis. The next way, and this is usually in combination with the thickened ligamentum flavum, are these joints in the back. These are called the facet joints. At each level, so lumbar 4 and lumbar 5, you have an L4-5 on the left and L4-5 on the right. These have a nice, normal, smooth cartilage and almost be like ice rubbing on ice, or your thumbnail rubbing on your thumbnail. Very smooth, very soft. Well, from wear and tear, some of it genetics, small traumas throughout your life, you lose some of that nice cushioned cartilage in the joint. When that happens, you start to get episodes of bone on bone in the joints, and that's one of the contributors to back pain. So when people have back pain, it's extremely likely from these joints in the back. A way the body tries to protect itself is by growing extra tissue. It's trying to add more padding or slow down that motion. So in almost everybody, once you start to be older than 30, 40, 50, you get all this extra tissue in your joints, starts to get more thick, and then your range of motion decreases some because they are just less mobile. There's less free movement of tissue on the joints. That then starts to grow extra bone spurs or osteophytes. So when a patient asks if they have bone spurs on their spine, the answer is almost always yes. Everyone has bone spurs to a degree, whether it's on the front part, side part, or in these joints. So these bone spurs aren't that big of a deal if they're on the front here, if they're on the side. They only become a big deal if they are in the joints, because then they create pain, or more specifically, if they start to grow on the side here where the nerves come out. Those start to pinch the nerves and can cause the numbness and tingling down the leg, or the shooting pain down the butt, down the thigh, and in severe cases, weakness. It causes weakness in certain muscle groups, whether that's your quadricep muscle, so your thigh muscle, like it buckles on you, your leg gives out on you, or foot drops, so you can't lift your foot up, you're tripping over things. That could be from severe compression of different nerve roots. Usually it's the L4, L5, or S1, depending on which muscle group. So when these joints get very thick, they grow extra bone, they grow bone spurs, they start fusing themselves together, and that in combination with the thickened tissue over the spinal thecal sac starts squeezing all the nerves. That's what causes spinal stenosis. It's bone spurs, osteophytes, arthritis, thickened tissue around the nerves is the stenosis in the lumbar spine. So that's what the definition is. The way to diagnose lumbar spinal stenosis is the following: an X-ray. Usually it's at least 4 views: front view, side view, bending forward, bending backwards. Those are the main ways to see that. Now, once you see the X-rays, the clinician, the physician, whoever the doctor is taking care of you, can also see if you have something called instability or spondylolisthesis of the spine. That's when one bone slips forward on the other. In younger patients, these could be in your teens, 20s, 30s, 40s. This could be from a pars fracture. This area of the bone is called the pars. A fracture here could be a little microfracture, but over time, it wears out. I have many other videos on that condition specifically. One of my favorite diagnoses because it has some of the best outcomes in terms of treatment, but I can come back to that later. A pars fracture is one way to have this all wear out, bone on bone, and then you get that stenosis, that squeezing of the nerves. The other way to then diagnose this is an MRI. Now, the MRI is different than a CT. A CT shows a 3-dimensional view of the bone or of the lumbar spine, whereas the MRI shows the nerves, muscle, and tissue. So a clinician, to see if there's a pinched nerve, really needs an MRI, whereas a CT is better to show the bony anatomy, the holes where the nerve tunnels come out, the amount of arthritis in the joints. That's how a CT and an MRI differ. Once you get the MRI, you can see how much stenosis, compression of the nerves there are, and then the doctor can then direct treatment to target that. And I'll go over the non-operative treatment next. Now, the other way you can get something called lumbar spinal stenosis, which I haven't mentioned too much yet, is a disc herniation. So it goes disc, bone, disc, bone, disc, bone, all the way down. If you get a disc herniation and it's big enough, it could push out and hit all the thecal sac that squeezes the nerves. If it's on the side, such as in this spine model right here, there's a little fake disc herniation right there that could hit this nerve root, and that just causes shooting down pain down one side of the leg. Similar in the neck for the cervical spine, but this talk is mostly dedicated to the lumbar spine. So that's another way you can get spinal stenosis, is a disc herniation that pushes out and squeezes the nerves. And if you imagine it like a house, a disc herniation would be like if the roof is, if the floor is coming up, squeezing everything inside, and the roof is this part here. So one of the treatments I'm going to talk about later is something called a laminectomy, where you just kind of shave off a slit of the roof and give everything more room, and then the surgeon can get down minimally invasively and take out that disc herniation. So once you have the diagnosis with clinical exam, X-ray, and MRI, that's how you determine there's spinal stenosis. Now, to determine the treatment, here's how I go about it. If you have weakness, that kind of forces the physician's hand that surgery is much more inclined, because that weakness needs to be operated on in a certain time frame. And that ranges depending on which publications you're looking at. That's usually has better outcomes in the first 6 weeks to the first 3 months to have the best outcomes to return weakness. If a patient just has numbness and tingling and it's tolerable, but they still want to get some treatment and the pain is tolerable, here's my algorithm. First, I start with dedicated physical therapy. The dedicated physical therapy is at least twice a week with a trained clinician, 2 times a week for 6 weeks. They work on things such as your back muscles, strengthening those, your core muscles, and the core muscles isn't just getting a six-pack, it's your quadricep muscles, hamstring muscles, your butt muscles, your glutes. Those are all key things to kind of strengthen up this whole area here. In addition to doing physical therapy, there are certain things I do support. I do support chiropractic therapy for the lumbar spine in terms of stretching, things such as acupuncture, things such as slight manipulations. I do not necessarily favor popping of the back or big twisting, just because there's not really any science there, and you do definitely expose the patient to more issues if you're just popping their back and trying to pop the joint. So I'm not going to fault someone for doing that in the lumbar spine. I would in the neck, but in the lumbar spine, there's no science to say that actually helps. In terms of stretching, deep tissue massage, those are all great things to try to alleviate the stenosis in terms of the symptoms of the stenosis. Now, in a way, that tightness never really goes away in terms of the spine. A disc herniation can get eaten away a little over time, and it could get a little smaller, but that stenosis really does kind of stay there maybe for the rest of your life. And if you're wondering, well, heck, shouldn't I just have surgery for it if it's there the rest of my life? Not necessarily. It's a very slow process. You can have a severe squeezing of your spine and be totally asymptomatic if it develops over a very long period of time. So me as the surgeon, I'm really trying to make surgery the last resort, and I treat the patients based on their symptoms, not on their MRI. And that's not me being special. I'd like to think 99.9% of other spine surgeons think that way. It's that I'm not treating the images, I'm treating the clinical exam and how bothersome it is for the patient. So the other thing that can help a patient non-surgically is partnering up with a pain management doctor. And this is where I think that spine surgeons should be the quarterback here. We should take the lead because we can do targeted injections to help. So I usually see the patient and then I send them off to a pain management doctor that I trust and that I know is ethical, and they work with me. We text all the time to different ones I work with to target the different nerves and the thecal sac. Now this does several things, the injections. One, from a diagnostic standpoint, if I can do a targeted injection at certain nerves, then one, it helps me identify exactly which nerve is being impacted. The MRI might show multiple levels having an issue, but it's probably just one, maybe two actual areas that are creating your issue. So that helps me narrow it down so that if we do need surgery, I can keep things minimally invasively. The other way that these injections are helpful, in addition to diagnosing, is the therapeutic aspect. If it can get you better for 6 weeks, 6 months, 6 years, that's great. That's a great way to avoid surgery. The whole goal here is just for us to buy time, is to calm down the symptoms while your body kind of acclimates to that tightness and the symptoms hopefully resolve, or maybe we're only flaring up once a month, which is much more tolerable, I would argue. So using these injections, they're essentially a steroid and numbing medication, calms down that irritation. It's not the tightness that's the issue, it's the irritation from the tightness. That's the main issue with any stenosis or squeezing of the nerves. So injections are a great way. Now these injections of the nerves and in the nerves here are different than what a lot of people are very familiar with, called facet injections. The facet injections, the rhizotomies, the medial branch blocks, those are more helpful in general for back pain, pain from arthritis, pain from bone on bone. That's not exactly the same thing as lumbar spinal stenosis, where the patient's nerves are being squeezed. When the nerves are being squeezed, the injections need to target the nerves, not the joints. So that's where maybe if you've had injections before and you think that a doctor's ordering injections for lumbar spinal stenosis, it won't work. These might be a different type of injection. So there's multiple different types. You can have it just down here where it hits everything. You can have it target a certain nerve, which is how I like to do it. That's why I like the doctor, not the pain management, the surgeon, not the pain management doctor. I like when they quarterback it because they can really target these injections and hopefully avoid surgery. So another aspect of non-surgical care that works really well is a Medrol dose pack. This is a 5-day course of oral steroids. It causes your body to also release its own natural steroids. Again, it just calms down that inflammation, buys us time, helps us avoid surgery. You can also use medications such as gabapentin, Lyrica, anti-inflammatories. Really, this is just things to help calm down that inflammation and essentially help buy us time to avoid surgery, making surgery a last resort.